Hello, good evening. Thank you so much for joining me here at the I Care for Your Brain weekly free brain health lecture. My name is Dr. Karen Sullivan. I am a board certified neuropsychologist, and for about 3 years now, I try to come to you weekly to fill what I consider to be a huge unmet need in the brain health community. And that is in the worlds of education and empowerment, which I think go hand in hand. In August of this summer, I had a wonderful opportunity to go really in depth with a relatively rare movement disorder called orthostatic tremor. And when I learned more about this condition, I was very intrigued to learn more. I found it really loving home within this community. People have been so kind to me for my focus and the attention that we've given the disorder here on the channel, that I just feel as if I want to keep following up with this condition and offering more and more education to this community. And many of you who aren't affected by what we call OT probably have not heard of this condition, and this is one of the missions of this I Care for Your Brain outreach program, which is the more we can demystify brain health conditions for the world, the less isolated and alienated our brain health community folks will feel, because more people will understand it and the symptoms won't seem so unusual. So OT is a movement disorder, and notice I keep using my air quotes because my big thing is it's not just a movement disorder. It is a neuropsychological disorder that has both cognitive, emotional, and sensory symptoms in addition to having a high frequency tremor. And typically, though, in the clinical medical books, it gets written up as difficulty standing over time due to a high frequency tremor in the legs and in the trunk. And it kind of gets written up as a disorder where people cannot stand, but they can walk. And that seems a little bit unusual to people who don't get it. And like I said before, we have to make this commonplace information if we're really going to support these people in our community. So these folks can also have a lot of unsteadiness when they're standing over time and a lot of dizziness. And there's a lot of fear of falling. And what we see over time is that used to get written up as a fear, but didn't necessarily manifest in falls. It was kind of a form of anxiety. But the more I learn about the condition, the more I can see that falls are really a part of it. And so that's incredibly difficult on your everyday functioning. Think of how many things you do while standing that you really take for granted. Standing in the shower, waiting to get some American cheddar at the deli counter. And so what I really learned about this condition is where it's focused in the brain. We're learning that more and more every month in the scientific community. And what are the other constellation of symptoms that go along with OT? So as a neuropsychologist, that's where my heart lies in this community. I like other people to manage the tremor and some of the physiological symptoms that can manifest. And what I really want to shine a light on is more of these what we call non-motor symptoms in OT. So what I like to do is every month or two, I'll just go on and search the scientific journals and type in orthostatic tremor and just see if I get anything back that kind of feels like it falls within my category. And so that's what I did recently, and I thought, wow, this is a cool article. I want to share this with people online. So at this time in brain health research, we've pretty much convinced the research community that OT is focused of the progressive degeneration of cells within a part of the brain called the cerebellum. The cerebellum, the big question though, is it just acting in isolation? We know that there are both direct and indirect connections to the cerebellum to other parts of the brain, the frontal lobes, the parietal lobes, the motor cortex, a place called the thalamus. But all of that hasn't really been super sorted out yet. And the big issue though is clinically, even though the folks who do academic research get that OT is not just shaking, it really hasn't trickled down into the clinical world yet. So what I mean by that is when a person with OT goes to see their neurologist, goes to see sometimes even a movement disorder specialist, they are not going to get the validation, the assessment, and the treatment of the non-motor symptoms. So when I did my webinar back in August, that's all I focused on, a 2-hour webinar where we went through the mild word finding difficulties that can happen, coordination, the trouble with subtle eye movement coordination, difficulty with emotional regulation, and really how you can think about what the cerebellum does is it's the great coordinator. And so it isn't just the coordination of movements and picking up something. That's old school. We don't think about it like that anymore. We know that the cerebellum, it's finally understood as a neuropsychological center of the brain. So if you have OT, the thought of many of us is you're going to have these other subtle symptoms, but where I feel like I have power and control is taking the information right to the people and hoping that you are in medical relationships where maybe you can educate your provider about some of these symptoms. So my thought is when these symptoms go under-identified, under-validated, like I said, under-treated, that this is adding an extra layer of disability to OT that doesn't need to be there. And that's what really motivates me every day to be the best neuropsychologist I can be and provide these services here on free Facebook and meet with all of you, is because there's no excuse for that. If it just comes down to access to information, there's no reason that I can't get my butt up here every day after work and give you guys this information. Information should not be exclusive. It should not be something that people only have a small amount of access to. Most research is actually sponsored by the government, and so I wish we would do a better job at rolling the information back to the people that it actually impacts the most. So I want to get to this article about OT, and what it focused on is gait. Now, you know me, I don't like lingo, I don't like jargon. So already gait, I'm like, why can't we just use a word that makes sense to most people? Basically, gait is like the manner in which someone walks, okay? So when you walk, you're not just walking, you're doing all sorts of things that we're going to talk about tonight. But what's cool about this research is it once again reinforces the idea that OT is housed in the cerebellum, and it's so much more than shaking while standing, okay? So most people have talked about OT as a condition that you can get relief from once you start to walk, and the tremor kind of goes away, okay? So in 2018, this kind of got turned around a little bit when they were able to show that the tremor is actually persisting when people walk. But the new idea as of 2 years ago is that y'all are doing unconscious, subtle compensation movements with the rest of your body that are now stabilizing the tremor. But the consequence is that your gait gets off, okay? So the manner in which you walk gets wonky. And so one thought is like, is that what's behind the dizziness? Is that what's behind the falling, right? So I was really interested in this study. So here's what we knew prior to the study, right? We definitely knew that standing is abnormal in OT. So they've done research on people without OT, and there's a certain number of inches that your feet are supposed to be when you are standing, okay? And in clinical brain science, one of the things you might notice your neurologist or your neuropsychologist has you do is walk, and they watch you. And we're looking for like 20 different things. One of the things we're looking for is how far apart are your feet when you walk? Do you have a wide-based gait? And what we know this indicates is that there's a cerebellar issue. If you start to think about how people act when they're under the influence of alcohol, this is what you start to see. It's a way of steadying yourself so you take up more space and you're more steady on your feet, less likely to fall. So we know that when we watch folks with OT walk, and I know I have some info on this in the webinar, it's like 50% wider stance than folks who don't have ET, okay? In the brain, this is one of the many, many awesome, cool things about being a neuropsychologist, is you really start to look for little qualitative indications of where in the brain the problem is, okay? And so what I mean by that is not even a picture, not even necessarily test scores, but things like when the cerebellum is damaged, what you typically see is that things get bigger, okay? Drawings can start to get bigger, handwriting can get bigger, emotions can get bigger, okay? Retrieval times can get bigger. What we see when other parts of the brain are affected, there's an area called the subcortical region that's affected in Parkinson's disease, a whole bunch of structures in the middle of the brain. It's the opposite. Things get smaller, handwriting gets smaller, steps get smaller. So already we know with OT, okay, we've got building evidence that what we're looking at here is a cerebellar issues. Here's the thing though, most research was done in controlled settings where they had people get on like a treadmill and then they watched them walk, not exactly a real world condition. So I'm already liking this research I'm going to talk to you about tonight because they're trying to look at real life, and that's what I'm all about. That's all what my graduate studies were about. It's all about, to me, how can we give people science-informed, practical recommendations that are actually going to improve daily function and quality of life? So here's what they did in this study, okay? This was 18 people who had primary OT. They did testing to see they didn't have any comorbid issues. They didn't have essential tremor in addition to OT. And they looked at 18 age match controls. So for in this group, they had 10 females, 8 males. The average age was starting at 70 and then plus or minus about 6 years, okay? And they matched that up with the controls. Most of the people in this study had their OT for about 14 years, but there was a range where some folks were about 7 years before that and some people were about 7 years after. They put these people through a large battery of standardized tests, and they looked at how they walked, their balance, their eye movements, their history of falls, all the elements that actually go into walking, right? So remember I said before, walking is not just like one thing. It's incredibly complex. It's very multifactorial. And what they were trying to do is figure out what specifically is going on with the walking of people with OT. So what did they find? Every single research participant in this study showed something called a saccadic smooth pursuit impairment of eye function. So maybe you were with me for my webinar and you know that poor coordination of the eyes is one of the things that goes wrong in the cerebellum. And now here's what we find. 100% of the people in the study had difficulty with the smooth pursuit of their eye movements. So again, getting rid of jargon, what the heck does this even mean? So you might know, right, when you go to the doctor, a doctor might put a pen in front of you or a light, and what they do is they want you to keep your heads totally still, and they put an object about 3 feet away. And what they want to do is just see how your eyes follow the object, and they go in every visual field. So you want to go horizontal, you want to go up, you want to go down. When the eyes are working well, your eyes can start in the middle and very smoothly go right to the target, okay? So what they're saying in this study is that folks with OT tend to over or undershoot. And what that means is you stop just before the object or you stop just after the object, okay? How do you think that would feel to be inside of a visual system that was constantly, and it's subtle, it's probably unconscious to most of you, but my thought is this where we're getting the dizziness that we know happens in OT? Is it really an eye movement disorder? So remember, again, I'm all about the practical stuff. So what does this make me think? Well, boy, does this underscore how important healthy eyesight and healthy vision is in OT. We don't need cataracts on top of this. We don't need an untreated astigmatism. We don't need people wearing dirty glasses, okay? We need people to prioritize their eyesight. So my thought is, using this research, when we have OT follow-ups, can we start to apply some of this stuff and say, until we find a cure for this condition, let's take away every other layer that may be adding to your risk of fall, your reduced quality of life. These things are really, really important. So almost 90% of those with OT in the study also showed postural instabilities as indicated by something called a Romberg test. And even though you might not know that phrase, you might have done the Romberg test. So this is the one where you stand in front of the doctor and they have you close your eyes and they watch to see what your body does. Now, a positive Romberg is when somebody starts to go like this. You might even have actually kind of fallen over. And we think of losing balance, you know, to a subtle or to a more severe degree, is indicative that there's a breakdown somewhere in the visual input system. So there's 3 sensory systems that go into the cerebellum. So there's vision, there's something called proprioception, which is our internal sense of where our body is in space. So if you close your eyes and I position your arm, you know, kind of funny upside down, if the proprioception system is working well, you should be able to say to me, Karen, you took my left arm and you kind of bent it down and it's at like a kind of like a 40-degree angle, okay? But there's also our vestibular system. This is sensations of body rotation, where we are in space, the effect of gravity on us, and our movement that comes in from our inner ear. So 2 of the 3 systems only have to be working well in order to maintain balance. So what we can do with Romberg is, if we take away the visual input, okay, and there's instability, well, now we've teased that apart from sensory issues. So there's something going on with vision and how the cerebellum controls remember, it's all about coordination. So it's the tiny little coordination points between objects. So, pretty significant. So, instability can also be due to plenty of other things, like trouble in the motor neuron system, both upper and lower, the basal ganglia. One thing they didn't say in the article that I was curious about is, was the difficulty with eye movements related at all to progression of disease? So did folks who had OT longer, we know unfortunately it is a progressive condition, the longer you have it, is it the worse your eye movements get? I'm going to venture to say yes. They also found impairments in walking in about 50% of the people. So people with OT indeed stand with a more broadened sense of support. So this is where that wide-based gait come in. But here is where we think the secret about why walking seems to take away the tremor that disables folks with OT is there's a lot more what they call, you ready for this, spatiotemporal gait variability in OT. Simple, this is staggering, okay? In New Jersey, we would call this herky-jerky. If you live in Pennsylvania, you might call this cattywampus. I'd be very curious to know what all you wonderful people in Australia would call, when somebody is kind of not, it's not quite straight, right? Something's a little bit off, not well coordinated. Walking speed was moderately reduced, and even though our folks with OT have wider gait, what we're seeing is shorter steps and increased periods of double support. So I did not know what that meant. What that means is this is the period of time when both feet are in contact with the ground. Okay, this happens twice in the gait cycle, once at the beginning when you're walking and once at the end. But what they're finding is this happens about half as long in people with OT. So it's almost, again, think of the cerebellum as the finest coordination of smooth things that your brain does, right? Whether or not it's walking, whether or not it's finding your words, whether or not it's managing your emotions, right? That's how all of this is relevant to me. If we see it in gait, this is the same part of the brain we're using for emotions. And so we're kind of trying to tie those 2 things together. So gait impairments, the herky-jerky, the staggering, become very pronounced in folks with OT when they are slow walking, and they mainly disappear during fast walking. Okay, so when they did 2 things, people's walking got way worse. And I think this is one of those nuggets that we can pull out and use for advice for people with OT. The first one is when they took away the visual feedback. So this is when they asked people to either close their eyes, when they degraded their vision to a certain degree. So again, think dirty glasses, right? Think cataract, think old prescription that hasn't been updated. The other thing was they distracted these people by having them do a cognitive dual task. So what do I mean by that? That means that while someone is walking with OT, they really should focus on walking, okay? Probably having a detailed conversation, a meaningful conversation, is not going to be as successful as it would be otherwise, because it appears that so much attention has to go to walking successfully that it's literally taking up a lot of our brain power, a lot of our attention span. Again, this really underscores the importance of prioritizing vision in OT. All the patients with OT reported considerable impairments in physical function, and they reported moderate to severe concern about falling. Fall events in the last 6 months before the study were reported by about 1/3 of the patients. And what they really found predicted falls was slow walking. So to me, this leaves us with like a chicken or the egg kind of a thing. Do they walk slow because they've fallen and they want to be more careful? Or are they falling more because they walk so slow and we see there's a benefit in speeding up walking, but we can see that the walking also is a little bit staggering. So it is certainly complex. The conclusion that the authors come to is that the findings are reflected in OT people's report on limited physical activity and concerns about fall. So to them, at the end of the day, that's what this finding really means, is that because there's trouble with gait, we think that this adds to people being concerned about walking, worried about falling, and that this really keeps people, this is part of the disability in OT. So what they recommend, which I love, is that all comprehensive evaluations of OT must include an analysis of walking to identify if there is slowness, because slowness predicts falls, okay? So this made me think about physical therapy in OT, and you all need to help me with this one. One of the things that physical therapists do is not just rehabilitate someone after an event like a stroke. They also can teach people who are going to fall because of their brain health challenge to do things like fall better, fall and not hit their head, fall and not get as hurt as they would otherwise. And so I'm curious if any of you have been prescribed physical therapy. Sometimes in other countries they call it physio. If you guys have been doing physio things to work on balance in the vestibular system, I think that's really interesting. But really too, at the end of the day, the biggest take-home message about this research is probably that yet again, we've got another compelling argument that OT sets up in the cerebellum. And so when things are in the cerebellum, you are not going to just get movement disorder. You're not going to get motor symptoms like a tremor. The cerebellum does sensory, cognitive, and emotional things. And that is what I feel like my little contribution can be, is validating that, hey, you all, if you are struggling to find words, if you feel like you can't put the brakes on your emotions sometimes, could be many other things, but it also could be your OT. And I don't want you to be living with a fully invisible part of your brain health challenge. At least if we talk about it here, I think there's really a sense of relief, and I really think that it reduces anxiety in people. And again, to me, that's an extra layer of disability. So let's bring OT into the modern era, and let's stop calling it a movement disorder, and let's start calling it a complex neuropsychological disorder with sensory, cognitive, and emotional symptoms. This is the constellation of symptoms that I am interested in, that I described in that 2-hour webinar. So what we focused on is getting to understand the cerebellum. There's something called the cerebellar affective cognitive syndrome. We want to know what are the specifics on those word finding issues. There are retrieval issues with memory. Increased irritability and anxiety is very normal. If so much of your brain is consumed with standing and walking, and someone tries to bring up something even mildly stressful to you, a normal human being is going to snap back and be like, no, not now. That reaction, if that other person doesn't understand what's going on in your head, they're like, oh, he's walking, he's not shaking anymore, things are good. No, the brain is still incredibly challenged during that time in OT. In the webinar, I also talk a lot about the two most common medications, the clonazepam and the gabapentin. Before I got into OT, I had concerns about those medications. It's not to say you shouldn't take them. I just want you to be informed. So when we did this webinar, back in August, 2 hours for $57. And what I'm going to do when I'm done talking is put up a link for a half-off sale for the holidays. I just really want this information to be very accessible to folks. I wish in a perfect world I would love to give it all away for free, but I hope you all can appreciate that that particular webinar for 2 hours took many dozens of hours. I'm going to go between 100 and 200 hours of my time to put it up. And there's all sorts of expenses that you don't need to know about, but basically we're just trying to break even. We also use everyone's registration to give a nice generous donation to the very awesome people at the University of Nebraska Center. They have a great OT research and education fund. And when we did our webinar back in August, we were so psyched because we were able to send them a couple $100s, and it felt great. So I love that we have all gathered here together. I hope that you find this to be empowering, informative, and the medical system is changing, especially the brain health system. We have less and less time with our providers. We're really in the position to have to educate ourselves about our condition, and I just want you to have a trusted, objective voice, me, so you don't fall prey to exploitation, which I see all over the place in the brain fitness world. You know, pills, games, all of this stuff that I know is not based in evidence-based science. So my thought is I'm just trying to bring the scientific world a little bit closer to you. So I hope you guys have a great night. I'm not sure if I'm going to be back again next week because we got Christmas here in the US, but to all of you with OT across the world, it has truly been my pleasure to get to know you. You all are a wonderful, strong, generous sharing community, and I really appreciate how you have embraced me and brought me in. So thank you all so much, and I hope to be talking to you soon more about OT. Bye.